Audio course on cervical shortening during pregnancy. Episode 1. Why the cervix shortens. The first mistake in cervical shortening is to imagine the cervix as a weak door. That picture is tempting. The cervix looks short, the pregnancy is above it, gravity feels like the obvious enemy. So the mind jumps to mechanical solutions. Lie down, remove pressure, stitch the cervix, insert a device, stop working, stop moving. Sometimes anatomy matters. Sometimes a stitch matters. But if that is the only model, the resident will misunderstand the entire field. The better model is this. Cervical shortening is often the visible sign that the preterm parturition pathway has started to express itself at the cervix. Not always, not in every patient, but often enough that this should be the default mental frame. The cervix is not a passive plug. It is a dynamic organ. During pregnancy, it has to do two opposite jobs. For months, it maintains mechanical integrity and helps protect the intrauterine space. Then near term, it must remodel, soften, shorten, efface, and dilate enough to permit birth. That change is not simply the cervix failing, it is biology turning on. The clinical problem is when that biology turns on too early. So when you see a short cervix in the mid-trimester, do not ask only, how short is it? Ask a better question. What pathway is this cervix showing me?
Is it isolated asymptomatic shortening in a singleton with no prior spontaneous preterm birth? Is it recurrent cervical insufficiency? Is it early preterm parturition in a patient with a prior spontaneous preterm birth? Is it inflammation or occult infection? Is it membrane activation that may later become PPROM? Is it uterine overdistension in twins? Is it painless dilation with exposed membranes, which is no longer just an ultrasound finding? That is the course model. A short cervix is not one diagnosis with one treatment. It is a risk signal embedded in clinical context. Now let us build the biology. The cervix is mostly connective tissue. It contains collagen, elastin, proteoglycans, smooth muscle, blood vessels, and epithelium. Its strength comes from extracellular matrix structure, especially collagen organization. Cervical ripening means that structure changes. Collagen organization loosens. Tissue hydration changes. Glycosaminoglycans change. Inflammatory cells and inflammatory mediators become more important. Prostaglandins and nitric oxide participate. The epithelial barrier also matters because the cervix is part of the defense against ascending vaginal flora. So when the cervix shortens, the ultrasound is showing a macroscopic result of microscopic remodeling. This is why the phrase cervical length can be misleading. It sounds like we are measuring a simple dimension, like the length of a table. But in pregnancy, cervical length is also a biomarker of tissue state. The most important larger framework is the preterm parturition syndrome.
Spontaneous preterm birth is not one disease. It is a syndrome with several roots into a common pathway. That common pathway has three major expressions. First, cervical change. The cervix softens, shortens, effaces, and may dilate. Second, decidual and membrane activation. The interface between decidua, chorion, amnion, and cervix becomes biologically active. Extracellular matrix breakdown and fetal fibronectin release can appear. The membranes may become vulnerable to rupture. Third, uterine contractility. The uterus moves from relative quiescence toward coordinated contractions. Different patients enter that pathway from different doors. Infection and inflammation are one door. Cytokines, prostaglandins, matrix metalloproteinases, and inflammatory cell activation can drive cervical ripening and membrane weakening. In mid-trimester cervical dilation, GAB emphasizes how often intraamniotic infection is present. That is why dilation with exposed membranes is not just an anatomy problem. It is also an infection risk and prognosis problem. Decidual hemorrhage and vascular disease are another door. Thrombin and decidual activation can promote contractions and matrix degradation. A patient whose cervix shortens in a setting of bleeding is not the same patient as an asymptomatic patient whose short cervix is found incidentally.
Uterine overdistension is another door. Twins, higher-order multiples, and polyhydramnios create stretch. Stretch can activate inflammatory and prostaglandin pathways. That is why cervical length predicts preterm birth in twins. But prediction does not automatically mean that singleton treatments will work. Functional progesterone withdrawal is another door. Human labor often occurs without a major fall in serum progesterone. The issue may be local progesterone action, receptor function, and inflammatory signaling. Progesterone helps maintain uterine quiescence and opposes cervical ripening. That is why vaginal progesterone makes biologic sense for selected patients with a short cervix. But the same mechanism also explains its limits. If the driver is advanced infection, PPROM, significant dilation, bleeding, or overdistension, progesterone alone may not reverse the entire pathway. And then there is cervical tissue susceptibility. Prior cervical excisional procedures, uterine anomalies, congenital connective tissue differences, prior painless mid-trimester dilation, DES exposure, or prior cerclage history may lower the threshold for premature remodeling. This is where the older idea of cervical insufficiency still matters. But modern practice does not treat every short cervix as classic insufficiency. Pause here, because this is the key distinction for the whole course. Short cervix without dilation is a risk state. Cervical dilation with exposed or prolapsing membranes is a different clinical state. They may be related, but they are not managed as if they are identical. A 21mm closed cervix at 21 weeks in a singleton with no prior preterm birth is not the same bedside problem as 3 centimeters of painless dilation with membranes visible at 21 weeks. The resident reflex is this. Before choosing treatment, classify the context. Ask 7 questions. 1. Was the measurement transvaginal and technically valid? 2. What is the gestational age? 3. Is this a singleton or multiple gestation? 4. Is there a prior spontaneous preterm birth, PPROM, mid-trimester loss, cervical surgery, or prior cerclage? 5. Are there contractions, bleeding, leakage of fluid, fever, uterine tenderness, or discharge? 6. Is the cervix only short, or is it dilated on exam? 7. Are we in a prevention window, an acute preterm labor window, a PPROM pathway, or a peri-viability counseling situation? If you answer those questions, the field becomes much less chaotic. Now, let us deal with why cutoffs feel arbitrary. 25mm is important, but it is not magic. It is a practical threshold that approximates a risk percentile in the mid-trimester and allows trials and guidelines to define treatment groups. Risk does not suddenly appear at 25mm and disappear at 26. Cervical length is a continuum. In the classic IME study, risk of spontaneous preterm birth rose steadily as the cervix shortened. The shorter the cervix, the higher the risk. This matters because a resident who treats 25mm as a cliff will make 2 errors. They will over-reassure at 26, and they will over-medicalize every patient at 25 without asking the clinical context. The better phrase is this. 25mm is a decision threshold, not a biological switch. The same idea applies to the treatment window before 24 weeks. It is not that the cervix stops mattering after 24 weeks. It is that the best evidence for prevention with vaginal progesterone and cerclage is concentrated in the mid-trimester prevention window. After that, the question increasingly shifts from prevention to surveillance. Preterm labor triage, steroid timing, magnesium when appropriate, neonatal counseling, and delivery planning if the pathway declares itself. Now, test the model on 3 patients. Patient 1 is 21 weeks, singleton, no prior spontaneous preterm birth, no symptoms, TV ultrasound cervical length 18mm, closed cervix.
This is the cleanest short cervix prevention patient. The finding is real if the technique is correct. The resident should think vaginal progesterone. Do not jump to cerclage. Do not prescribe 17-OHPC. Do not prescribe bed rest as treatment. Patient 2 is 21 weeks, singleton, prior spontaneous preterm birth at 30 weeks, cervical length 18 millimeters.
Same number, different patient. Now, prior history changes the pretest probability that shortening is clinically meaningful. Cerclage becomes a serious discussion, especially if the cervix is very short, and current guideline frameworks differ in how they present progesterone versus cerclage. The history changed the meaning of the number. Patient 3 is 21 weeks, painless dilation, membranes visible. This is no longer just a cervical length lecture. Now the resident must evaluate labor, PPROM, infection, bleeding, fetal status, gestational age, and whether exam-indicated cerclage is appropriate. The risk has moved from prediction to an acute management decision. That is the whole course in miniature. Cervical shortening is not one thing. It is a sign that must be interpreted. Let us close with the model we will reuse in every episode. First, make the measurement trustworthy. Second, decide whether the cervix is short, dilated, symptomatic, or associated with membrane rupture or bleeding. Third, place the patient in the right population. No prior spontaneous preterm birth, prior spontaneous preterm birth, twins, or special high-risk history. Fourth, choose the intervention only after the phenotype is clear. The resident reflex is this: do not treat the millimeter. Treat the clinical story that gives the millimeter its meaning.